Hey guys, welcome to Medifaction. Today, let's learn about hypertension. So basically, there can be two conditions. One, where there is low pressure, which is termed as hypotension, which results in inadequate organ perfusion, dysfunction, or tissue death due to decreased oxygen supply. And on the other side, we have a high pressure condition known as hypertension, which results in end organ damage and finally atherosclerosis. So, if there is a sustained diastolic pressure greater than 89 millimeter mercury or sustained systolic pressure in excess of 139 millimeters of mercury, the patient is associated with high risk of atherosclerosis. Essential hypertension. Approximately 90% to 95% of hypertension is idiopathic, which means the cause is unknown. This is termed as essential hypertension. This is a multifactorial disorder as well because it can be associated with multiple genetic polymorphisms and interacting environmental factors. Next, we have secondary hypertension. This is the hypertension resulting from an underlying cause like renal or adrenal abnormalities. Accelerated or malignant hypertension. A small percentage of hypertensive persons shows a rapidly rising blood pressure that, if untreated, leads to death within a year or two, called accelerated or malignant hypertension. Severe hypertension, that is, systolic pressure over 200 millimeters of mercury and diastolic pressure over 120 millimeters of mercury. This can be due to renal failure or retinal hemorrhages and exudates with or without papilledema. Now let's see the types and causes of hypertension. I have already mentioned that there are two types, that is essential hypertension and secondary hypertension. This idiopathic condition is called essential hypertension, that is 90 to 95% of all cases. When it comes to secondary hypertension, there we have some subtopics like renal, endocrine, cardiovascular, and neurologic. In renal conditions, it may be due to acute glomerulonephritis, chronic renal diseases, polycystic disease, renal artery stenosis, renal vasculitis, renin-producing tumors. This all can cause hypertension related with renal. When it comes to endocrine, there can be due to adrenocortical hyperfunction like Cushing syndrome, primary aldosteronism, congenital adrenal hyperplasia, liquoric ingestion, etc. Likewise, some other reasons are exogenous hormones like glucocorticoids, estrogen, sympathomimetics, and tyramine containing foods, and also monoamine oxidase inhibitors. We also have pheochromocytoma, acromegaly, myxedema, hyperthyroidism, and even pregnancy-induced causes related with endocrine. When it comes to cardiovascular, we have polyarthritis nodosa, increased intravascular volume, increased cardiac output, rigidity of the aorta can cause hypertension. In neurological causes, we have psychogenic, increased intracranial pressure, sleep apnea, acute stress, including surgery. Now let's see the regulation of normal blood pressure. The blood pressure is the product of cardiac output and peripheral vascular resistance. So, any factors which interferes with these two entities can cause alterations in blood pressure. Let's see what all. In case of cardiac output, the blood volume and cardiac factors can interfere. Blood volume is interfered by sodium amount, mineralocorticoids, atrial natriuretic peptides, whereas in case of cardiac factors, heart rate, and myocardial contractility can cause alterations in cardiac output, which cause alterations in blood pressure. In case of peripheral resistance, there are humoral factors and neural factors which can cause constrictions and dilations with the help of certain other factors. When it comes to constrictors, there are angiotensin II, catecholamines, thromboxane, leukotrienes, endothelin, which all can contribute in constriction of the vessel, whereas prostaglandins, kinins, and nitric oxide can cause dilations. Some other local factors like pH and hypoxia can cause alterations in the peripheral resistance as well. So here we have a flowchart for understanding the regulation of blood pressure. Suppose in a person there is decreased blood pressure. So when a person experiences a decreased blood pressure, it will be sensed by our kidney due to decreased glomerular filtration rate. So due to this, the kidney produces a proteolytic enzyme called renin. This renin then cleaves the angiotensin produced by the liver, resulting in formation of angiotensin 1. But this angiotensin 1 is inactive in nature. So in order to get active, the angiotensinogen converting enzyme helps to make angiotensinogen 2, which is active. So in order to maintain the BP, there are three major mechanisms. First one is by acting on adrenal gland. So when the angiotensin 2 acts on the adrenal gland produces aldosterone, and this acts to kidney through renin angiotensin aldosterone pathway, and the kidney thus results in resorption of sodium and water, by which the blood volume will be increased and the blood pressure is maintained. The next mechanism shown by the angiotensin 2 is that it acts on the blood vessels directly and causes vasoconstriction, resulting in increased blood pressure. And also the third mechanism, which is the angiotensin 2 acts on the renal tubules, and thus resorption of sodium takes place, which increases the blood volume and also increases the blood pressure, and thus attaining the normotension. Now let's see the pathogenesis. I have already told that 90 to 95% of essential hypertension is idiopathic, and there is secondary hypertension also, renovascular hypertension, which results in renal artery stenosis followed by decreased glomerular flow and pressure in the afferent arterioles, resulting in renin secretion and thus hypertension. How renin causes hypertension has been discussed in the earlier slide. Next is single gene disorders. Gene defects affecting enzymes involved in aldosterone metabolism, and also mutations affecting proteins that influence sodium resorption can be a cause. Mechanisms of essential hypertension. We have already told that this is multifactorial. Therefore, there are certain factors such as genetic factors, reduced renal sodium excretion, vasoconstrictive influences, and also environmental factors. Now let's move on to morphology. There are two forms of small blood vessel diseases named as hyaline arteriosclerosis and hyperplastic arteriolosclerosis. First, let's see in detail about hyaline arteriolosclerosis. These are homogeneous pink hyaline thickening with lumen narrowing, plasma protein leakage across injured endothelial cells, and increased smooth muscle cell matrix synthesis in response to chronic hemodynamic stress. Here you can perfectly appreciate the thick pink ring surrounding the light pink lumen, which represents the hyaline deposits. Now for the next type, that is hyperplastic arteriolosclerosis. These are due to severe, that is malignant hypertension. Here we can appreciate the onion skin lesions, which are concentric laminated thickening of the walls and luminal narrowing. Smooth muscle cells with thickened, reduplicated basement membranes, and also fibrinoid deposits and vessel wall necrosis in the kidney. Hope you have understood the video. Like, subscribe, and press the bell button for more videos. Thank you. Thanks for watching.